Sí,
Nahue,
sí.
Nahue, Adri. Nahuel, Nahue, 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 claro, ¿ves? Sale.
Hola, hola. ¿Me escuchás? Perfecto. Probamos primero español.
Hello.
¿Te escucho? Te
No
escucho.
escucho yo.
Dale.
Están hablando. Hola, doctor
¿Te
Tassi.
escucho?
Sí,
Te escucho
pronto.
perfecto. Genial.
Hello.
Sí,
Hello,
ahí
doctor
voy.
Tassi.
Yes, I'm here.
Ah,
Here I am.
nice to meet you. I'm Mariana from the technical support.
Hello.
Hello. Would you like to share your screen and put your
Yes.
presentation in order to check it?
Okay, of course. So here you are. Can you see it?
Not yet.
Okay.
Now I can see it.
Okay, that's great. So I try if it works.
Yes.
I have, okay, just for look at the first video.
Okay.
Okay, it's now. Okay. Okay. I think that everything works, so I can stop the sharing. Okay. So everything was okay for you?
Yes, perfect.
That's
In
good.
order you could hear the interpretation, you have to go to the English channel. Down in your screen, you have interpretation.
Yeah, técnica inglés, sí.
English, yes, English.
Okay.
There you will listen the interpreters in English.
Ah, okay. That's good. So it's at 2 o'clock, is correct? So in 25 minutes.
Yes, 25 minutes. Okay.
Okay,
Yes.
but I will be back. See.
You will see a screen. Now, ahora. Can you see it now? A blue screen with the name of the Congress and the...
Yes, it's in the upper part on the left. So
Okay.
Congreso LACE 2022, 22 and 23 of September.
Yes, there you have the room.
Yes.
You will see the coordinators and the videos and everything that it's happening in the Congress.
Okay, thank you so much. That's great. Okay.
Yes, we are going to check the mics of the room.
Yes.
Okay.
Nahue, ¿me habilitas el audio de Lancelot Online? Así escucha a la doctora. Nahue. Chicos, no sé si hay algún
Doesn't
coordinador.
know your name, and your heart beats like a subway train. Ooh, it makes you wanna die. Ooh, don't you wanna take her? You wanna make her all your own. Maria, you've gotta see her. Go insane out of your mind. Regina, Ave Maria. A million and one candlelights. This thing before is my best friend there, the boy next door. Ooh, for love and on fire. Coming from the rain, she sells shims running down the drain. You as ice and desire.
Dr. Tassi, can you hear me? Hello, Dr. Tassi, can you hear me? Dr. Tassi, can you hear me? Ahí está hablando el intérprete. Hola, intérprete, ¿me escucha? Pero no escucha, no hay nadie ya. Hello, Dr. Tassi, can you hear me? Hola, intérpretes, ¿me escuchan? Hola, hola. Hola, intérpretes, ¿me escuchan? Ah, hola, intérprete. Ah, ¿qué tal? ¿Qué tal? ¿Me escucha? Pues parece que la doctora debe estar, no sé, no está ahora en la pantalla como para chequear la traducción. En inglés. Sí, 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 sí. Perfecto. Sí, 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 sí. Bueno, bárbaro. Probamos. Sí, hola, hola. Sí, se escucha perfecto. Sí, hola. Sí, perfecto.
Bueno, Liga.
Buenos días. Vamos a ir comenzando el Congreso. Nuevamente, buenos días a todos y a todas. Es un gusto tenerlos a todos acá nuevamente, después de largos 3 años de no vernos en forma presencial. Así que esperemos que todos podamos disfrutar de este nuevo Congreso, que tiene algunas características diferentes y ahora las vamos a mencionar un poco. Antes que nada, quería, como en cierta manera, dejar nuestro agradecimiento al actual past president, el doctor Silva, ya que el año pasado y el anterior tuvo que hacerse cargo de la peor parte y diseñar los congresos virtuales, y que realmente salieron muy bien también, pero que fue todo un desafío, así que muchas gracias a él. En cuanto al congreso de este año, van a ver que si bien estamos todos presencial y en el salón, la gran mayoría de los invitados extranjeros, mejor dicho, todos los invitados extranjeros, van a estar conectados en forma virtual. Todos ellos van a estar en vivo, salvo uno que ha mandado su charla grabada, pero va a estar luego en vivo para contestar las preguntas. Y si bien nos perdemos la interacción personal con ellos, que muchas veces tenemos en un almuerzo o en una cena, la verdad que esta modalidad también tiene muchas ventajas. Una de ellas es para ellos, no tener que viajar hasta la Argentina, que no queda muy cerca, para a veces dar una charla o dos, estar un día o dos y regresar, lo cual era complicado, sobre todo teniendo en cuenta que son por lo general personas muy ocupadas, con agendas muy llenas, y no es que se queden para hacer turismo. En segundo lugar, para nosotros, los costos nos bajan considerablemente y eso nos permite tener más invitados o más expertos invitados al Congreso, dado que obviamente tiene un costo inferior. Así que esperemos que podamos aprovechar las charlas. Tenemos una linda pantalla, así que vamos a verlos bastante bien y esperemos que no nos falle ni internet ni nada de todas esas cosas. En segundo lugar, se van a encontrar que hay todo un bloque donde se van a hacer la presentación de los trabajos. Este año reabrimos la presentación de pósters y decidimos darle como un lugar para presentaciones en plataforma, breves, esto sí, o sea, tenemos 7 minutos por póster en total, no tenemos más, pero todas aquellas preguntas que queden después obviamente las pueden agotar en los stands cuando estamos durante los breaks. Espero que todos puedan participar de esto también, porque para mí es como muy importante poder darles un rol a los más jóvenes, entusiasmarlos, que se incentiven en seguir generando conocimiento y trabajos. Estamos saliendo de una época muy complicada, donde a ellos particularmente les tocó ir mucho más al frente de batalla que a nosotros, donde no la pasaron bien, donde se les vino un poco abajo también su tiempo dedicado a la formación, y quedó más que de manifiesto que eso no necesariamente se retribuye económicamente como corresponde. Eso ha generado un desánimo en muchos médicos jóvenes, no solo en la Argentina, en varios países, así que esperemos que los podamos incentivar con esto, que es lo académico, sí que pierdan de vista que la medicina podrá ser una vocación, pero es una profesión, es un trabajo y como tal tiene que tener su retribución económica, y que sigan luchando por eso. Así que esa será una segunda parte diferente, y por último van a encontrar también que hay un bloque que va a participar la licenciada Ivana García, que es la que creó y preside el espacio conocido como Espacio Epilepsia, que es una plataforma que está destinada a llevar conocimiento sobre la epilepsia a la comunidad en general, a los pacientes, pero también a los médicos, y que ahora se va a agregar con algunos trabajos con nosotros. Nos va a hacer trabajar a nosotros, algo que no es fácil, a veces a los médicos nos cuesta romper esa barrera, y hacer algunas cosas que se salgan de lo habitual, así que estemos abiertos a eso que va a ocurrir hoy durante la tarde. Así que sin más, esperando que todos puedan disfrutarlo y que nos comenten luego aquellas cosas que podamos mejorar, la voy a llamar a la doctora Gabriela Ugame, que va a presentar a la primera speaker del día. Gracias.
Hola, buenos días a todos. Un gusto otra vez estar acá presencial. Un aviso parroquial antes de empezar, por favor silencien los celulares, así no interfieren con las conferencias. No sé si ya la doctora Tassi está conectada. Bueno, buenos días, doctora Tassi. Es un placer tenerla acá en nuestro congreso, la mayoría de nosotros ya la conocemos. La doctora Tassi es médica neuróloga y neurofisióloga, responsable del laboratorio de seguimiento a largo plazo del programa de epileptología clínica y en el Centro de Cirugía de Epilepsia del Hospital Claudio Munari en Milán. Como todos la conocemos, la doctora tiene más de 160 artículos publicados en la temática de epilepsia, así que estamos muy contentos de tenerla acá. Bienvenida, doctora, y le doy paso a su charla, que el tema de hoy va a ser epilepsia del cuadrante posterior. Luego de la charla vamos a dejar un espacio para preguntas. Gracias, bienvenida.
Muchas gracias. I'm very happy to be with you this afternoon. And of course, I would prefer to be with you in Argentina, but probably it will be the next time. So it's a very difficult talk because we are going to talk about the posterior quadrant epilepsy that is not well-known form of focal epilepsy. I am, as it was said, a neurologist, and I'm working in the Claudio Munari, so the dedicated to Claudio Munari Epilepsy Surgery Center in Milano, in Italy. So why it's very difficult to assess this kind of epilepsy? Because we consider as posterior cortex epilepsy those seizures that are arising from the occipital, the parietal, and what we define as the occipital border of the temporal lobe. So the posterior part of the temporal lobe, including the basal part, or from any combination of the regions. It means that, unfortunately, we have no clear anatomical, clinical, as neurophysiological data among these regions. And the epileptogenic regions are not always limited within the anatomical border of these regions. In some authors' opinion, this kind of epilepsy should be grouped all together, as usually when they start in one of these three lobes, as well in the posterior part of the temporal lobe, the symptomatology could be really similar and misleading about their localization. Unfortunately, they are very rare, so the frequency is very low, and it's very difficult also to understand where is located the epileptogenic zone. And the surgical treatments for this kind of epilepsy is less common to respect, for example, temporal lobe epilepsy, but as well to respect to frontal lobe epilepsy. So we can consider, but the literature is very scarce in terms of quantification of this kind of epilepsy, that occipital seizure arises from this lobe in about, is less than 3% of the total amount of focal epilepsy, and that the parietal cortex epilepsy is about 6% of patients, especially with refractory focal epilepsy. So we are talking about what? We are talking about the parietal lobe, so everything that is after the border, so the Rolandic fissure, the occipital lobe without any kind of very strict or anatomical boundaries in between, on the lateral part of the brain, in between the occipital and the parietal, and of course what we call the posterior or the carrefour, so the boundary in between parietal, occipital, and temporal lobe. What is important is to know that, on the contrary, we have a very clear-cut boundary in between the parietal and the occipital cortex on the medial surface of the brain, represented by the parieto-occipital sulcus. But in the other case, the boundaries are really no clear-cut in the three regions. So what about the functional anatomy of the parietal lobe? Of course, everyone knows that on the posterior part of the Rolandic fissure, we have the primary sensory area, and that the majority of the parietal cortex is an associative cortex. And we have different regions in between the primary motor cortex, and as well as in the motor cortex, we have a sensory homunculus. That means that some region has a larger area because we need a more important control, for example, for the sensitivity and the motor aspect of our hands. And we have a very clear-cut differences in between the importance of the region controlling the hand movement and the sensory part of the cortex to respect, for example, the leg, as well as the face is an important part because we talk with our face, we have the facial expression, so we need larger area to control this region. But we have other area in the parietal lobe. So for example, in the area named 43, we have the secondary semimotor cortex that is located and is allocated for the gustatory skill. And then the majority of the associative parietal cortex is formed by the superior part and the inferior part of the parietal lobe. And inside this region, we can find very important high cortical function. For example, the tactile three-dimensional interpretation, what we call the stereognosis. And inside the parietal lobe, we develop the programs, the motor program that are necessary, especially to reach a pre-established target. Of course, we have the spatial memory and the perception, and everything is in collaboration and in strict association with the visual skills that are more located in the occipital lobe. And of course, we have also the visual interpretation of the object that we are able to see. Which are the symptoms and signs in the parietal lobe seizure? The problem is that we do not know very well the function of the parietal lobe, so it's very difficult to interpret and to appreciate the symptoms starting in this particular cortex. Of course, we may have symptoms that are linked to the primary sensory cortex, as well as paresthesic sensation. So tingling, stings, tickling, that usually are segmental, and usually they tends to spread from the distal to the proximal part, and followed by segmental clonias. And sometimes in half of the seizure, we may have Jacksonian seizure with a progression of the symptom on our limbs. We may have pain, even if nowadays we consider that pain is more associated with seizures that are starting from the insular cortex. And we may have a very infrequent sensation, as well as the disorder of our body images, the thermal dispersion, the ideomotor apraxia. That means that we are not able to move or to control a part of our body without any kind of loss of consciousness or awareness. We may have dizziness because we think that the vestibular part of our cortex is located in the inferior part of the parietal lobe. Of course, gustatory hallucination, as we know that the gustatory primary area is located in the parietal operculum, and a very infrequent apraxia, calculia, and ataxia, and sometimes a negative myoclonus. What about the occipital lobe? Of course, the occipital lobe receives what we see in the visual field. In the mesial part is located in the mesial part of the occipital cortex, and the generis stria separates the upper part that is what we see in the inferior part of our visual field, and the inferior part of this primary cortex receive what we see in the superior part of the visual field. Of course, the rest of the occipital regions are associated areas that are very important for the interpretation of our visual symptoms. So we have, of course, the visual associative cortex, the area 18 or V2, and the peristriata, the area 19. And we have, starting from the occipital cortex, two kinds of systems. The first one is the superior visual system in collaboration with the parietal cortex. It is also named as the WARE system because it's utilized for the spatial perception, such as, for example, the localization of our body into the space and the localization, the movement of the object, especially when we want to reach the target. And we have the inferior visual system that is also named the WAT system in collaboration with the temporal cortex that is very important for the visual identification of the object. So what are you looking at? And of course, for the comprehension of the written language, so the lexia, and the vision of colors and the recognizers of faces. Of course, we have other associative cortex, especially the areas 18 and 19 that are absolutely important in the control of the eyes movement. So as we have seen where and what, so the where is occipital parietal, the what is occipital temporal, and these two systems are completely different in terms of composition on the anatomical point of view and cellular point of view. And as you can see, even is also the visual latency is completely different. So is shortened in the dorsal, so the where system, because the where system is very important to perceive any kind of danger for our body or for the other. So we need a shorter latency in this case, as is larger in the ventral one, because we do not need to recognize in very few milliseconds a person that is very close to us. Of course, it's not surprising that most of the symptoms and signs that are linked to occipital lobe seizure are visual. So we may have, but once again, is absolutely infrequent, a complete amaurosis. So the complete loss of our visual possibilities. We may have a simple visual hallucination, sometimes in association with the amaurosis that can be located even in a quadrantic part of the our visual field. Of course, when we are very close to the temporal-occipital region, but even in the intraparietal sulcus, we may have a complex visual hallucination, and of course, movement, so deviation of the head, and always, quite always associated with the head deviation of the eyes. And if you look at some papers about this kind of seizure, so posterior cortex, as you can see, the more tissue, the more, so most cortical, when most cortical are involved in the generation of the seizure, the more the symptoms are complex. So if you look at when we have just parietal discharge, we may have this kind of seizure that are really monosymptomatic, so one symptoms, but if we are located more anterior, for example, in the junction of the temporoparietal occipital cortex, we may have complex visual hallucination or visual loss or dysmorphopsia. So the symptoms became more complex if more amount of the cortex is involved by the ictal discharges. And of course, in the ictal symptomatology in a seizure starting from the occipital lobe, we may have the blindness or amaurosis, visual illusion, palinopsia, or sensory hallucination of ocular movement. And what is ever seen is that the electroencephalography is very difficult to use. And sometimes we may have misleading results in interpreting this kind of discharge and even of the interictal abnormalities on the EEG. The first thing is to be sure that our patient has a correct montage if you want to correctly recognize and localize our epilepsy. So as in this case with the pre-cabled cover, we may have a dislocation of the electrode. There's it's a very big mistake, and in this case we are not able to correctly localize our seizures. So be careful about the montage of our patient. Once again, we have a lot of papers talking about parietal lobe seizure, but even if you look at the symptoms that are reported in this kind of bibliography, you can find symptoms that you can put on the, for example, temporal lobe seizure or frontal lobe seizure. So except for paresthesia, there are no symptoms claiming particularly for a parietal origin. So few cases just for looking at the differences that we can encounter in patients having posterior quadrant epilepsy. So this is the case of a patient that started having seizure at the age of 10 with 2 clonic seizures, and he had the diagnosis of idiopathic benign occipital epilepsy. But he has a lot of seizure, and despite anti-seizure medication, he is still going to have a seizure, especially during sleep. And at the age of 16, he started having seizures completely different that were characterized by the presence of colored illusion, hallucination that were localized in the top part of the left visual field. Then he had the starring, a loss of awareness, gestural automatism with the left superior limb, and then a deviation of the head and the eyes to the left. And it was the EEG at the very onset of the seizure, so when the diagnosis of benign occipital epilepsy was done. And as you can see in both the posterior part of the brain, we can recognize these three-phasic sharp elements, but that even at that moment were more expressed on the right part in the temporo-occipital region to respect to the left one. This is a sleep EEG, and also during the wakefulness we can observe a differences in between the background activity on the left part, in which it was more regular, and on the contrary, with more abnormalities located in the right posterior part of the brain. Here again some example, and here again another discharge. It was an infraclinical discharge, so without any kind of ictal symptom or signs, that was located apparently just on the posterior part of the right regions. Here again, in 2014, the situation was absolutely quite the same, but with the complete disappearance of the abnormalities on the left side. So what we were faced with at that time was the presence of slowing and a spiking activity just on the temporo-occipital regions. As well here, so a burst of polyspike, especially during drowsiness, and that were more important during sleep, as in this case, with this kind of polymorphic spiking and fast activity and slowing, again located more on the temporo-occipital regions to respect the parieto-occipital region on the same side. The MRI was absolutely normal, and the PET scan, as you can see, showed a very punctual hypometabolism that was located in the lateral cortex of the occipital regions. That's why we decided, on the basis of the EEG, the clinical information, and the PET results, to explore this patient with the intracerebral electrodes. And as you can see at the very end of the SEG, we performed what we call a thermocoagulation. So we burn part of the cortical malformation. And since then, so it's about now 8 years, the patient is seizure-free. But it means that even if the first clinical sign was the presence of a very simple visual hallucination, we may have this kind of manifestation arising not from the medial part of the occipital lobe, but from the lateral part of the same lobe. So we have to be careful in the consideration of this clinical sign. In our case, so a patient starting having seizure at 16, she may have 2 different kinds of seizure, one without any kind of subjective manifestation with loss of awareness, cyanosis, then a deviation of the head and trunk to the right side, and if she were standing, she can fall down. And the second one, and she stares, and she asks his husband or a witness to stay very close to her, as he was frightened about something. The eyes were staring and wide opened, and she smiles. And as you can see, we have this kind of tumor lesion. It was after surgery determined as a disembryonal epithelioma that was located in the superior part of the right parietal lobe. It means, for example, that in this region, the symptoms, for example, could be the head and trunk deviation on the homolateral side. So be careful, because especially the posterior part of our brain, we cannot localize or lateralize with only the side of the deviation of the head and of the eyes. And be careful again with the EEG. So this was the interictal EEG that apparently was absolutely normal. And again, sometimes, especially during the sleep, we may have, so remember the lesion was located in the superior part of the parietal lobe on the right side. We may have this kind of spiking activity that could be located more anteriorly to respect the location of the anatomical lesion, both on the temporal and on the supracilian regions, and probably is better localized by the transverse montage. And once again, for example, we may have, and this could help in misleading localization, this kind of burst of spiking and sharp activity that was just located on the temporal lobe that has nothing to do with this kind of epilepsy. And this is the recording of the seizure. At the very onset, it's very difficult to assess if there is any modification on the EEG. But in the second part of the seizure, we may have this very fast activity that is located in the temporal-occipital region, and it was really less visible, even if we have this kind of spike that is just located on P4. And then we have a growing up activity that is more visible in the second part of the seizure, and then a very precocious involvement of the frontal lobe and of the whole temporal lobe on the same hemisphere. So sometimes, again, the symptoms are not really so particular, so pathognomonical of this region, and even the EEG could be very difficult to be interpreted even during the ictal discharges. And this is the only real interictal abnormalities that we have seen, but it was just after the seizure that was correctly located, or that can correctly help us to localize the region in which the ictal discharge can start. In kids, it's more complex again, because sometimes they are not able to refer any kind of subjective sensation. And it was the case of a very young kid that was 18 months when he was explored in our center. And he has this kind of dysplasia involving quite the whole occipital lobe on the right side. But as you can see in kids, it's very frequent to have this kind of encephalopathy EEG, in which it's very difficult to assess if there is a predominance of the interictal abnormalities on one side. Yes, we can discuss this. Probably we have a predominance, as in this case, of the abnormalities on the right temporal-occipital junction, as well as for the spiking activity. But as you can see, we may have bilateral posteriorly located abnormalities, as in this page, and especially during the sleep, in which a secondary synchronization is more possible. And for the ictal deviation of the head and the eyes, look at this seizure. So we have to consider this is a right occipital lobe seizure. So look at the eyes of the kid. So the mother is quite appreciating that there is something that is going wrong. And then he's trying to play with his father, but then he stares. Okay, and look, he has a homolateral deviation with this kind of important blinking. And just in the second part of the seizure, the deviation of the eyes is to the contralateral side. So once again, he has a second very brief seizure. Once again, and the second part is more similar to spasms that you know very well, especially if you are a neurological pediatrician. But once again, do not try to localize and lateralize with the deviation of the eyes and the head. And this is the ictal EEG. And once again, it's very difficult to assess the side of the discharge. We had the impression that probably the discharge is faster on the posterior part of the right hemisphere, as in this case, or in the temporal-occipital region. But then we have also a slowing activity, rhythmic theta activity that is bilaterally located. And this is the shortest seizure following the first one. And in this case, we are more able to appreciate the differences in between the right posterior region and the left part. And then the kids have what we call spasms. So fast activity, but then a slow wave with a very high amplitude in which he has, of course, a deviation of the eyes, but also the elevation of both arms and the flexion of the head. So in kids it's more difficult. Sometimes it's very difficult to appreciate because the symptoms are very little. This was a woman with a cavernoma that was, as you can see, located in the somatosensory primary area, so in the parietal area, in the hand area, on the left side. So this is a seizure that we recorded. Look at the right hand. And as you can see, she just has a dystonic posturing of the right contralateral area without any kind of hypertonus or clonic movement. And she has a paresthesia in the same part of the body before this dystonia. And when the seizures are so little and the epileptogenic zone is so little and is located in the motor cortex or in the primary sensory cortex, as you can see here, you are the ictal EEG. There are no modification of the EEG because the part of the cerebral cortex is so little that it is impossible to appreciate the modification with the extracerebral electrodes. So be careful when you say that the patient has a psychogenic seizure because the EEG is negative, so consider as well the anatomo-electroclinical elements to judge. And here again, a right parietal epilepsy. And once again, look at the head. So the deviation is homolateral once again, and look at the left hand. And this is what we can define a parietal hand, because the patient is unable to control the movement and the position of the hand just because she has the impossibility to have a good function of the primary sensory cortex, especially in this region. And once again, as you have seen, we have an homolateral deviation of the head that is quite frequent in parietal lobe epilepsy. And once again, on the EEG, it's very difficult because once again, we have the impression that the most involved cortex on EEG is the temporo-occipital region, even if this patient had this kind of malformation of cortical development. It was a focal cortical dysplasia type 2 that was very far from the temporo-occipital region, and it was located just in the superior part of the right parietal lobe. And another thing that is quite frequent in parietal lobe epilepsy is kind of dissociation in between the deviation of the head and the eye. So look at this patient. She had a right parietal lobe epilepsy, and as you can see, she had a right deviation of the head, so homolateral to the epilepsy, but a left deviation that was contemporary to the right deviation of the head of the eyes. So this kind of dissociation usually is a hint to consider the possibility that the epilepsy of the considered patient arises from the parietal lobe. Look at these kids. The parents refers a deviation of the eyes to the left side. So look, the first deviation is to the left, but then he has kind of clonic deviation to the contralateral side, so to the right, with the blinking. And then a third ocular deviation, once more to the contralateral side. It was a temporo-occipital epilepsy. So the visual symptoms on the head and eyes movement are really very difficult to assess, especially if you are faced with just the anamnestic data. This was the ictal EEG that was contemporary to the seizure that I showed you before. And as you can see, once again, we have the impression that the ictal discharge is bilateral, but is really faster on the temporal-occipital junction. And in this case, we were faced with this kind of tumoral lesion that was located in the lingual gyrus and associated with quadrantanopia on the superior contralateral fields. Sometimes the visual movement, the ocular movement are more complex. So look at this patient, he has a strabismus, but then he has this kind of oscillation of the eyes that apparently are not conjugated. So every eye seems to work separately from the other one. And it was an intraparietal left epilepsy. And against the patient with this kind of lesion in parieto-occipital cortex, once again, a strabismus, so a nasal deviation of the right eyes, while the left one remains the axis. And if you have seen, this patient has a chapeau de gendarme sign that usually we utilize for a location of the symptomatology of the epilepsy in the frontal lobe. So be careful, because we have to consider the whole of the symptomatogenic aspect of the seizure, and especially the chronological appearance of every kind of symptom and sign during the seizure. And once again, parietal seizure can give us a different type of seizure. In this case, for example, seizure were different depending on the state. So in sleep and wakefulness, they were completely different. It's a left parietal epilepsy. And in sleep seizure, he has this kind of dystonic movement, and then some clonic movements on the right side and also on the contralateral superior limbs. But when he had seizure during wakefulness, the symptomatology was completely different, because he had this kind of hypermotor seizure with the screaming, so it's like as the state of the brain can influence the appearance or not of different symptoms during seizure, but it suggests us that from the parietal lobe we may have a dystonic asymmetric posturing seizure, as well as in the premotor area in the frontal lobe, and as we may have as well hypermotor seizure that usually we recognize more frequently located in the frontal region. So once again, be careful. And here again, the last case is with the patient in pink, the focal cortical dysplasia was located in the medial part of the junction in between parietal, occipital, and temporal regions. And once again, look at the eyes of the patient. He had a strabismus in the contralateral eyes, so the right one. And here you are the very onset of the seizure on the SEEG recordings. And he has this kind of very erratic, confusing, and very difficult to describe symptoms, especially located on the face, so kind of blinking, then this kind of staring. He opens his eyes, he seems frightened, that deviation to the left, and then the head to the right side, and then to the left again, and then he tries to cover his eyes. And then we have the impression on the SEEG that the seizure was finished, but not on the clinical point of view. And it was explained by the onset of a discharge involving the more anterior part of the temporal lobe. Then the kid will have a temporal lobe seizure in the second part of the seizure, with an orientation of the head, some oral alimentary automatism, some gestural automatism with the homolateral hand, so the left one, and kind of dystonic posturing of the contralateral hand. So this is a seizure which onset is located in the posterior part of the brain with a propagation to the medial part and anterior part of the temporal lobe. So the anatomical boundaries are quite never respected by the ictal discharges. So if you want to conclude, posterior quadrant epilepsy are really infrequent, but probably there are a big amount or a certain amount of seizure that we interpret as frontal as well as temporal. There are not neither frontal nor frontal because we have not all the skills or the experience to interpret these different and complex signs and symptoms arising from the posterior cortex. And these patients are really of a difficult classification because the visual system is our principal system in terms of sensitivity. And also the body and space integration is, of course, involved. And you know very well that the interpretation of symptom and sign, depending on associative area, are really more difficult to respect, for example, primary sensory area. And that it's not so infrequent to be faced with discrepancies in between the anamnestic data and the recorded seizure. So parents or the families or the witness to the seizure may refer symptoms that are not the first one or that are not correctly located because they are not able to understand the ones to the right or the left, or first to the right and then to the left. So in these cases, it's better to submit this patient to a video EEG recording, and especially do not try, never, to localize and lateralize with the head and eyes deviation. And once again, the EEG is more difficult to interpret, to respect to frontal lobe epilepsy and of course to the temporal lobe epilepsy. So especially when it's mesial. So please, this is a hint, but use the transverse montage because sometimes it's more useful to localize this kind of epilepsy. And as well, we may have a very brief involvement of the frontal part of the brain, and this is a problem and inducing errors and mistake in the through localization of this kind of epilepsy. And of course, is absolutely fundamental the role of video EEG, and of course the role of the analysis of, for example, the subjective symptoms that are referred by the patient, referred by the family, the interictal and ictal data, and of course the anatomical data from the MRI. But even the MRI should be done with the hint to look at the posterior part of the brain, and this is starting from the epileptologist to the neuroradiologist. And so, thank you very much for your attention and your patience.
Gracias, doctora Tassi, por su presentación excelente. Siempre aprendemos mucho cuando la escuchamos. Así que bueno, ahora vamos a dar paso a la sesión de preguntas. Allá hay una mano levantada. Vamos a pedirles que hablen en el micrófono, así la traductora puede transmitir la pregunta. ¿Alguien quiere hacer alguna pregunta? Doctora García, ¿quiere empezar? No, se arrepintió.
I was so clear. I'm happy.
La vamos a hacer hablar a la doctora García.
Bueno, buenos días para nosotros, buenas tardes, Laura. Muchas gracias por la charla.
No se escucha bien.
Ella me está escuchando, me parece.
Sí, sí.
Tenemos problemas internos con la comunicación acá.
Sí, sí, don't worry.
Uno de los síntomas que solemos ver en algunos pacientes del cuadrante posterior, o que por lo menos pensamos del cuadrante posterior, es la desviación cefálica no forzada, generalmente con el mentón hacia abajo, que suele ser ipsilateral. y que siempre representa un desafío para localizarla dentro de lo que es a su vez el cuadrante posterior. Hemos tenido algunos pacientes a quienes les hemos hecho estéreo EG y que finalmente he decidido no tocarlo porque no he podido realmente clarificar bien la zona de inicio. Quería saber si usted tiene alguna experiencia con respecto a este síntoma en particular dentro del cuadrante y si hay alguna forma de abordarlo diferente.
The problem is that this kind of symptom, we may have it in different parts of the brain. So, for example, the very anterior part of the frontal lobe, and as you suggested, usually in the temporo-occipital junction. I think it's very infrequent in the more posterior part, so in the occipital lobe, in which usually we have a forced deviation, but not with the flexion of the menton, and or we have a clonic deviation of the head. So I think that the flexion and the deviation, forced deviation, is more located near to the temporo-occipital junction, but as well we may have it in very anterior part of the frontal lobe. So once again, it's very tricky to try to understand the origin of the seizure with just one sign, because a seizure is not one sign. So a seizure is successive signs and symptoms, and we did to interpret there with the chronological aspect of the signs.
Gracias. Si a nosotros nos ha resultado a veces muy difícil poder, creo que eso también tiene lo mismo, nos ha resultado muy difícil cuando es el síntoma inicial, que muchas veces ya no vemos la zona de inicio, sino vemos la difusión, ¿no? Y eso es lo que a veces me ha por lo menos llevado a tomar la determinación de no tocar al menos ese paciente en ese momento determinado. Le paso al doctor Silva, que tiene otra pregunta.
Gracias, muchas gracias.
Bueno, hola Laura, muchas gracias por la excelente presentación, como siempre. Una pregunta que nosotros tenemos y que cada tanto nos encontramos, pacientes que tienen algún antecedente perinatal con lesiones a veces glióticas, muchas veces bilaterales, y también muchos casos de ulegiria que a veces son unilaterales, y a veces hay o no un compromiso contralateral, y en ocasiones pensamos que son unilaterales, y hay un porcentaje de pacientes que son bilaterales. Hemos tenido algunas malas experiencias de implantar esos pacientes y finalmente no poder ofrecerles nada. ¿Qué sintomatología o qué elementos usás en esos casos con lesiones bilaterales para decidir la implantación? Y si la estrategia es bilateral, es bilateral asimétrica, bilateral simétrica y completa, porque eso también encarece mucho los costos. Gracias.
Thank you for the question. They are very complicated patients because we may have two types. So patient having bilateral lesion, and they are the more frequent probably. In this case, usually, if you look carefully at the recorded seizure, not the anamnestic data, because with the anamnestic data is impossible to understand, but usually they have bilateral seizure. And it means they may have a seizure with the eyes and head deviation to one side, and then 5 seconds again to the contralateral side. But in these cases, we may have patients having, I don't know, 90% of the seizure starting from one side and 10% of the seizure starting from the other one. In these cases, I think that a bilateral implantation is the correct way to do, even if at the very end, you can try to reduce the number of the seizure in this patient, or sometimes even to render this patient seizure-free, but you cannot touch, of course, the anti-seizure medication because the other side is epileptogenic as well. In the monolateral patient, so having just one side with the anatomical lesion, sometimes we have not to forget that even if in the contralateral side there are not anatomical lesions, they may have very little lesion that is not visible on the MRI. So once again, I think that we have to start for the very long, prolonged VDOG monitoring, and we we have to try to record the higher number of seizures to determine if for sure they are monolateral, and then you have to try to implant. And the second problem in both the types, so bilateral and monolateral, is the visual field. It's because the bilateral, usually they have an amaurosis of a loss of the vision. So a surgical intervention in one region determines an hemianopia. And if you have an amaurosis and then the hemianopia, it could be very difficult to share it. And of course, once again, if you have an amaurosis and a strabism, even if in a monolateral patient, sometimes the choice, surgery yes, surgery no, could be very difficult depending on the risk of inducing a visual deficit after surgery. But they are very complicated patients, I agree with you.
Hola, acá. Hola, doctora Tassi. Le quería hacer una pregunta sobre termocoagulación. En uno de los casos nos había contado que habían realizado termocoagulación y quería preguntarles en su centro si se lo realizan a todos los pacientes con este tipo de epilepsia, si hay algunos pacientes que son candidatos y cómo interpretan la respuesta y si a todos le realizan cirugía después de la termocoagulación o aquellos que responden directamente los continúan en seguimiento. Gracias.
Gracias. We perform a thermocoagulation usually in about 90% of our patients that are submitted to SAG. We have long-lasting, impressive results in patients having periventricular nodular heterotopia. It means that in this case, if you coagulate the epileptogenic zone, so not just the nodules, but the epileptogenic zone determined on the recording of seizures, we may have quite 70% of patients that are seizure-free after thermocoagulation. The results are completely different, for example, in focal cortical dysplasia, in which if you coagulate just a part of the focal cortical dysplasia, it means that we have a percentage of patients seizure-free after thermocoagulation is, I don't know, about 5% probably. But in these cases, we use thermocoagulation for having a prognostic factor. It means that if the patient had 3 seizures per day before the thermocoagulation, and then he had 1 month of seizure-free period after the thermocoagulation, it means that surgery has probably very high probability to cure the patient. In cryptogenic patients, once again, the results are not so good. So we have about 14–15% of the patient seizure-free after the thermocoagulation. But I think that we have to use this methodology because sometimes could be excellent, could give excellent results in patients with a long-lasting duration, and also because it's a kind of helping in determining the possibility of cure the patient with surgery.
Hola, ¿qué tal? Buen día. Buen día, muchas gracias por la presentación. Quería hacerle una consulta acerca del caso neuropediátrico. Sobre todo, ¿qué rédito diagnóstico tienen ustedes en su experiencia con el PET en estos casos inespecíficos que tienen resonancia normal? Y si ustedes tienen algún estudio en relación a estos casos inespecíficos con síndromes genéticos que puedan orientarlos a la terapéutica médica, sobre todo.
Yes, it's a very difficult problem. One, because depending on the age of the patient, if you want a PET, you have to be a PET with a sedation or a general anesthesia. So not all the centers could have this kind of examination before surgery. The second is that in kids it's more difficult to assess and interpret the results of the PET, especially in patients having a normal MRI. And I consider that nowadays, when we are faced with the kids with normal MRI and AG with multiple multifocal or bilateral abnormalities, I think that an NGS panel is mandatory before to propose any kind of, not surgery, but pre-surgical step. Because I think that in the past, in adults and kids, so in both, probably we have operated patient having a genetic syndrome, I'm not talking about a DEPDIC5 mutation, but patient probably with a channelopathy, so SCN1A patient or protocardian patient, without knowing it. So be careful in kids, and when we have doubt, especially if the kids have a mental retardation on a retard of the cognitive development, I think that genetic examination is really mandatory.
Hola, buenos días, muchas gracias por la charla. Bueno, en epilepsia posterior, fuera de lo que es los déficits campimétricos asociados, la parte cognitiva de la visoconstricción y la orientación espacial es bastante difícil de evaluar por las baterías existentes. Quería preguntarle si tienen alguna batería cognitiva para evaluar funciones del cuadrante posterior y qué experiencia tienen en cuanto a secuelas cognitivas de la visoconstrucción y de la orientación espacial en ese sentido.
It's a very difficult question because there are no such a specific tests for the posterior quadrant, of course, except for the visual function, but these are not neuropsychological examination. In our experience, an hemianopia is well tolerated depending on the age of the patient. I mean, the younger is the patient, the easier is to live, even if with an hemianopia. The problem with the kids is that frequently we are not able to assess if before surgery there is already a deficit of the visual field. And the other deficit on the cognitive point of view, I think that we have one patient, so we operated 2,500 patients, and the posterior part of the quadrant represents about 20% of our population. And between this patient, we have one patient with an alexia, but then with a very important amelioration during years, and one patient with difficulties to the orientation in the space. So it means that if the contralateral posterior quadrant is correctly working, and the patient is not an old patient, or he has not a long duration of epilepsy, you can propose surgery without very high risk of neuropsychological deficit induced by surgery.
Voy a irme ahora al extremo opuesto de la pregunta del doctor Silva, en un paciente con una epilepsia del cuadrante posterior, pero no lesional, donde a pesar de que tenga una semiología o una electroencefalografía que pueda ser lateralizadora, pero al ser no lesional vamos a progresar con un estéreo EG, si siempre conviene hacerlo bilateral, dado que tiene una rápida bisincronía o no, o si tengo elementos suficientes me puedo quedar con solamente hacerlo en un hemisferio.
Perfecto. See, if the semiology and the EEG and all the auxiliary examination, I don't know, high density EEG or PET or SPECT or what you want to use are indicating a monolateral origin of the discharge, I think it's better to have more electrode on one side than a bilateral exploration. Of course, we know very well that the bilateralization in the occipital lobe is faster even to respect to the frontal lobe epilepsy. So sometimes it's really difficult to appreciate a lateralized onset. So in this case, of course, a bilateral exploration is mandatory. If not, if you have enough data, monolateral is better.
¿Alguna otra pregunta? Ahí levantaron. Hola, Euge.
Buen día, doctora. En un paciente con semiología, crisis con semiología clara de la región occipital izquierda, con electroencefalograma donde las crisis comienzan claramente en esa zona, pero que tiene signos imagenológicos de esclerosis hipocampal homolateral. ¿La cirugía debería incluir o no resección de la región hipocampal, con una evaluación neurocognitiva con buenas, o sea, sin déficit claro de memoria verbal?
I think we have a patient exactly the same, so a patient with a tumor in the occipital region and seizure, starting with the flashes in the contralateral upper part of the visual field, but having an hippocampal sclerosis on the same side. So we operated the patient. The patient was seizure-free for 1 year from the occipital seizure, and then she started again, but with temporal lobe seizure. So I think that in these cases, probably because there is a diffusion from the occipital to the temporal lobe, probably an invasive exploration before surgery is better. Because when you have any discrepancies in between the anatomical, the EEG, and the electroclinical data, I think that you have to explore the patient to be sure where we have to perform surgery. But it's very infrequent, but very tricky patient. So 2 possible origin of the seizure, but probably just 1 with the diffusion of the discharge in the second part of the seizure.
Gracias. ¿Alguna otra pregunta? Bueno, muy bien. No hay más preguntas en el auditorio. Nuevamente, gracias, doctora Tassi, por estar con nosotros y abrir el Congreso con esta charla súper interesante y desafiante para todos los que hacemos epilepsia. Así que, bueno, la dejamos en libertad. Gracias por estar con nosotros y esperamos...
Gracias a todos.
Hasta luego.
Chao. Chao.